Hello, thank you for inviting me to discuss my case with you this afternoon. So mine is the case study of a young patient with valve disease. So Mr. K is a 42-year-old gentleman who initially had a telephone consultation with his GP. He phoned up first because he had an episode of when he was running up a hill, he felt very dizzy and lightheaded, and then actually lost consciousness while he was exercising. So this is on the background of about 18 months of shortness of breath on exertion and some chest tightness, but had never had any episodes of syncope before. He is a relatively fit and well gentleman. He doesn't have any significant past medical history. He's an ex-smoker, having stopped about 10 years ago. He has minimal alcohol intake and is fully independent. As you can imagine from his presenting complaint, he's a pretty active gentleman, so he exercises at least 4 times a week and runs on a regular basis. His exercise is a combination of weights, but also aerobic training. And he's a member of air cabin crew. His only significant family history on direct questioning was that he thinks his grandmother might have had a heart murmur, but he's not particularly sure. So after the telephone consultation, because of his sort of worrying symptoms and the fact he was a young and active man, the GP did ask for him to come in for an inpatient review. So on examination, she found a harsh ejection systolic murmur. There was no evidence of heart failure, so the apex beat was not displaced, and there was no evidence of peripheral or pulmonary edema, and there was no radioradial or radiofemoral delay. He had some blood tests done, which were predominantly normal. Showed a normal BNP and normal HB and just a mildly elevated cholesterol. He had an ECG taken which showed sinus rhythm with just LVH, and then based on these symptoms was referred up to cardiology, obviously for the worrying heart murmur. This was his echo carried out within the cardiology department, so you have a parasternal long axis and short axis showing the aortic valve there, and then a closer up of the aortic valve. Color Doppler through the parasternal short and long axis there, showing no obvious regurgitation. And then this is the CW profiles through the 5-chamber of the aortic valve. And you can see there quite a large Doppler profile, and that's coming down to a Vmax of 5.27 with a mean pressure gradient of 75 and a max pressure gradient of 110 millimeters of mercury. It was tested again in the 3-chamber just to be confident, and yes, it is still having a Vmax over 5. The rest of the echo showed essentially a good LV systolic function with a normal aortic diameter. So his TTE does show that he has very severe aortic stenosis and what was apparent to be a bicuspid aortic valve. He has good LV function and normal aortic measurements on the TEE and some mildly elevated PA pressures. He also underwent a CT to check his coronaries and to look for any aortopathy or coarctation, all of which was normal. So in summary, this is a 42-year-old male gentleman who's presented symptomatic with very severe aortic stenosis with a bicuspid valve, previously fit and well, and with a very active job. Of note, his job requires him to work long, irregular hours and frequently being away from home. And so regular medication was not something that would be very easy for him to ensure, nor blood tests on a regular basis. At work, he needs to operate heavy aeroplane doors and perform CPR if necessary, and he wants to continue a high level of exercise, both weights and aerobics. So the question for the MDT for this gentleman would be, which intervention should he undergo, which valve type? And the other sort of question is, in this sort of post-COVID world that we're in now, with the predominance of virtual consultations, are we worried about our young patients with valvular heart disease having the diagnosis missed?
Thank you very much. That's a really interesting question, or 2 questions really, that you've posed there for us. So you've got, as you say, a young patient, 42, that is going to be flying all over the world on shifts and is concerned about anticoagulation, which would normally be our default that we would be suggesting, I suppose, a mechanical valve in this patient. So we should bring in the rest of the panel now. So if I could ask the panelists with us to turn their cameras and microphones back on, and then we can have a discussion. So Rashmi, you were just talking in your talk about a 33-year-old. This gentleman's just a little bit older, has concerns about being a flight attendant, long-haul flights, difficulty with warfarin, possibly. Do you go into, should I start off with self-monitoring, the CoaguCheck systems and other such things? Is that something that you've got many patients that use and find helpful?
I don't actually. Interestingly, I'm not aware of any of my patients using that, but I'm aware of data suggesting that use of self-monitoring systems and self-dosing of warfarin does improve compliance and outcomes. So I actually don't have patients who use this, but I can understand from a young 42-year-old patient's perspective, particularly with the job that he has, that he's reluctant to have warfarin for the rest of his life, as was my young patient. And it feels like a long commitment for the rest of the life to be having warfarin. It really well highlights all the issues that young people face when they have to have a mechanical valve.
Yeah, absolutely. I'll bring in John. John, do you want to add your thoughts on this?
Yes. Can you hear me all right?
Yes, we can.
Yeah. This is we see obviously a lot of patients like this, and we would want to talk about the Ross procedure, which I know you mentioned in your lecture, Rashmi. And we have 2 or 3 surgeons. We're lucky in that we have 2 or 3 surgeons in our unit who perform the Ross procedure, and so this is exactly the sort of patient who would be suitable. So somebody who doesn't want to take warfarin, but who wants as long a lived biological valve as possible, which you absolutely cannot guarantee with any of the new xenografts at all, because as Mamta correctly said, although there's promise with the Inspiris, until we actually get the data, we don't know that it's going to last longer than other types of xenograft. So I think this is exactly the sort of person that we would push towards or suggest might go towards one of our surgeons interested in the Ross procedure. And the disadvantages, in my experience, is that there's something like a 3 or 4% need for early redo to modify a procedure, possibly a little bit lower than that. Maybe it's 2% now. It started off in our early experience as a certain number needing a redo procedure. But thereafter, by 20 years, even at this age, there's still very good durability.
I agree with you. So in our aortic MDT, young patients like this would definitely be put forward for a Ross procedure. But of course, there are limitations in that not all patients are anatomically suitable. So the young guy that I spoke about, he unfortunately had dilatation both of the aortic annulus. So the aortic annulus was measured at 32 and his pulmonary valve was measured at 22 millimeters. So unfortunately for him, he's anatomically not suitable. There's too much discrepancy between the two. And the pulmonary homograft can allow a 6 millimeter difference between the two, but his aortic valve is more than a centimeter larger than the pulmonary valve. So he unfortunately couldn't have the Ross procedure. Interestingly, the patient, when we were discussing the different choices, he was quite daunted by the idea of having a Ross operation, which is a more complex operation. And a question for you, Professor Chambers, do you quote your patients a higher mortality with Ross?
No, well, I mean, no, I don't actually. We don't have a higher mortality in this age group. Our mortality for any type of valve is 0. Actually, I'm pleased to say. So no, the answer is not. But I do quote what I just said, which is that a small proportion do require a revision early if anyone who does it and what technique they've used. If the valve's been put in, the autograft has been put in very slightly at an angle. I mean, if it's put in as a mini root, all well, but if you're putting it in as an inclusion, occasionally it's not quite settled correctly and it needs revision. But that, with increasing experience, that happens less and less, actually. So the other problem we occasionally have is that we find, or my colleague finds, that the pulmonary valve turns out to be bicuspid. We don't always spot it on echo, and that's another problem to add to what you've just said, although that's rare. But yeah, so you're right, there are obviously problems along with it, and I make it absolutely clear that the simplest procedure, quick operation, is a mechanical valve, but this is nonetheless to be thought about. And I think one of the advantages, not perhaps in this case, because of course he needs an operation rather quickly, but in general, I think one of the advantages of a valve clinic is that we're seeing our patients on a number of occasions, and the process of consent occurs over months or years, and gradually there's an education and a discussion between the patient and ourselves, and we can deal with things that they see on the website or in newspaper articles and so on. So consent becomes a much more balanced and comprehensive procedure than normally it is. Clearly, in this case, we need to make a decision very quickly, don't we?
I think what's really striking about the data, the Ross data, is how it normalizes life expectancy to an age-matched cohorts, whereas in all the other series of aortic bead bioprosthesis or mechanical valves, there's quite a striking attrition rate. By 20 years, you've lost about 70% of the patient population. And I don't yet know whether that is because the Ross patients are very carefully selected. Of course, they are young, and whether it's a part of the fact that they are very well selected in younger, fitter patients. And particularly for young women wanting to have a family, we would really try hard to offer them a Ross procedure, but with for the patients to be aware that it is a more complex operation. And certainly in our unit, we would quote a slightly higher potential risk of mortality with a Ross. I had a young patient recently, actually. She did her own research. Her father was a GP, and she came back and said that she would rather have a minimally invasive aortic valve, prosthetic aortic valve replacement, rather than a Ross, which requires a sternotomy. And she just preferred the simpler operation. So as Mamta said, it's very much about shared decision-making, about guiding patients, and then ultimately, their freedom to choose what suits their lifestyle best.
Yeah, as long as their information comes from reliable sources. My concern, speaking generally about the informed patient, is how they get their information, and if they get it off websites that gives them unreal expectations about the durability of a TAVI procedure, for example, or a biological xenograft, based on data from people aged above 60 and they're 40, as happens, then that's not proper consent, and I am concerned about that. So yeah, so I agree with you, but ideally you have enough time that you can go through all these issues so that you have genuine consent.
Absolutely, I think, yeah, I agree 100%, completely.
And Prof. Sharma, if I can just bring you in here as well. So we've seen that this patient has stated that they want to continue a high level of exercise afterwards, both aerobic and weightlifting. For the patient with the normally functioning prosthesis, can I just, you did talk about this in your talk, that just for our audience, that they are free to do almost what they want to do if their valve is functioning normally and they're asymptomatic?
I think the sort of things that we need to take into account is that, a prosthetic valve is never the same as a native valve. And there is always a transvalvular gradient across this valve. Now, theoretically, there is a possibility, and I'm saying theoretically because there are no prospective studies actually examining the impact of vigorous exercise on valvular prosthesis, but, a very vigorous stroke volume and an increased preload and afterload could potentially accelerate, the deterioration of such valves. So we have adopted a rather cautious, and I should say consensus panel. It's a consensus panel approach, whereby the sort of what we apply to mechanical valves, the same recommendations as we would apply to an individual with a moderate abnormality with their native valve. So we would have the same guidelines for this individual as we would have with someone who has moderate aortic stenosis, a native moderate aortic stenosis, which would mean, engaging in moderate exercise, but clearly the exercise prescription would be very much based on not just the echocardiogram and the pressure gradient across the valve, but also ventricular function, and very importantly, on the effect of, on their functional capacity based on an exercise stress test, using either a peak oxygen consumption measurement, but also to check for exercise-induced arrhythmias or a blunted blood pressure response during exercise. The other thing that one has to, of course, remember is that there is the possibility of a coexistent aortopathy, which clearly isn't the case here. And even if his valve remained functional and he started to show features of an aortopathy, then I think if the aortic diameter exceeded 40 millimeters, that's the point at which we would also start talking about reducing the amount of isometric exercise that one is doing, particularly weight training and weightlifting.
Yeah, thank you very much. I think that's very, very relevant points there. Very shortly, we'll pass back to Dr. Bruce to tell us how this case finished. Rashmi, there's one question that's come through about the onyx valve and whether or not you're a fan of using the onyx in patients that have concerns about lifelong anticoagulation, and if their main concern is bleeding rather than the hassle of warfarin, whether you use it and recommend the INR of 1.5 to 2 with concomitant aspirin.
I don't use the onyx valve, so my standard prosthesis is St. Jude, but I have colleagues here at the Brompton who use the onyx valve as described in patients who are particularly concerned about bleeding risks, and they would recommend a lower INR for those patients, yes.
Excellent, thank you. Well, let's go back to Dr. Bruce then, shall we, to find out how this case ends. Thank you.
Sorry, yes, I picked up on all the important points in the case, and there was long discussions with the patient, and they were very adamant that they didn't think they could manage warfarin, and they were very worried about a large operation, so they underwent a minimally invasive aortic valve replacement with an Edwards Inspirish Resilia with a bioprosthesis, and are currently doing well.
Perfect. Thank you very much. Well, I think that that's a really useful case to kick off this session. It really highlights some of the challenges that we see in our practice, especially with younger patients and lifestyles and things. I mean, I think the one thing that obviously this patient will know at that age, having a tissue valve, I think all of us will be pretty confident saying you will be back at some stage. You will need a second procedure. And of course, at that stage, we don't know, if, as Professor Sharma has said, if these patients are extremely active. We know bioprostheses have a shorter lifespan in younger people. And then when that patient comes back, there'll need to be a discussion about what their treatment should be, because it's highly likely they could still be young enough to have a redo operation rather than a valve-in-valve TAVI at the age of 50, for example. But that's a great case to get us started. So thank you very much for that. And we will undoubtedly have more discussions. Yes, John.
Binoy, may I? Yeah, sorry.
Do you mind if I could ask, have you got a plan, or has he agreed a plan for life? I mean, not just this operation. Does he know that he's going to have a TAVI valve or whatever?
So he does know that, yes, it was discussed with him that there's obviously the risk of...
And maybe another, given his age, he might need 2, 3, 4 procedures.
Yeah, so he was counselled on...
Okay.
Yeah.
I just wanted to make the point, I think I made it in my presentation, that if we were to offer bioprosthetic valves to young patients, then it really has to be done very carefully, making sure that the valve size that's implanted is at least a 23 millimeter valve, making sure they do not have any peripheral access issues such as an aneurysm, although unlikely in a young patient, but one must plan for the future, as you say, and prepare for a second sternotomy, because he certainly will come to a second sternotomy, and possibly his third operation could be a valve-in-valve. But he will definitely need at least one redo aortic valve replacement, which can be done with a reasonably low risk.
Yeah.
Thanks.
Mamta, I'm sorry I didn't have time to come to you there.
No, all good points, I think. Nothing to add there. Really interesting.
Excellent. Well, thank you very much, Dr. Bruce, and we'll move straight on now to our second case.